mode. Okay, here we go. I'm going to start again. So I want to welcome Dr. Stanley Pollock to the JCC. He's a breast surgeon at Mercy Medical Center, which is part of Catholic Health Services, and he will be talking about why breast health screening should not be delayed. October is Breast Health Month, and it is really critical that we talk about breast health during this time. We do have, this is part of a Healthy Thursday series. Our next one is November 5th on heart health, and then November 19th on self-care during these stressful times. And they are stressful times, absolutely. So I want to introduce Dr. Pollock. Thank you for coming and sharing your wisdom with us.
All right, thank you very much for that introduction. And Judy, I welcome you to the little discussion here. And although it's a small, intimate group, I'll give the brief presentation as if it was a larger group, with the anticipation that maybe somebody else may view the recording at some date. So I've been asked to discuss the importance of screening for breast cancer. And first, people are sometimes a little confused about what screening is. And screening is basically a test that's done on people who are asymptomatic in effort to pick up a condition prior to it developing any kind of symptoms or signs. So that's to be differentiated from a diagnostic test. A diagnostic test is a test that's done on somebody with a problem with symptoms or signs, and to figure out what's causing those symptoms and signs. So a screening test is done on asymptomatic people. And for a screening test to be useful, it has to be done on some type of regular interval. And that interval usually depends on how expensive the test is, how painful or dangerous it is, and also the natural history of the disease. If the disease is a very slow developing disease, the screening interval can be longer. Or if it's a faster developing disease, the screening interval should be shorter. And in general, the year is used, the time interval of a year is used for screening mammograms, mainly because it's convenient and everybody remembers their birthday and everybody thinks in terms of years. So the year is the interval that we've all kind of settled on. Now, a screening test only speaks for your condition at that moment. It has no predictive value. It doesn't tell you what happened in the past. It doesn't have any protective effect. It doesn't prevent you from getting a condition. It just speaks for that moment. So although you had a screening test, let's say 5 years ago, that screening test is completely worthless today. It only spoke for that moment 5 years ago, which is in the past. It's not really relevant to today anymore. So a screening test has to be re-performed on a regular basis. And the screening tests are done for breast cancer, most commonly the mammogram, but also there's other screening tests that can be used. Sonograms, magnetic resonance imaging, what people call MRIs of the breast, and a newer test that's not widely available, but the machine is available. We do have a machine at Mercy called molecular breast imaging, which is essentially a nuclear scan. And that is used for screening, and it can be used for diagnostic purposes too. So first, people ask, well, why should I have a mammogram or any kind of screening test? What's the purpose of it? And basically, we know that screening for certain conditions reduces mortality. And by reducing mortality, that means that if you look at a population, there's some expected number of people who are going to die of a condition during a period of time. That's the mortality. If you screen for a certain condition and treat it when it's early, when the condition is earlier in its natural course, then you can decrease the number of people who die from that condition. So around about the late 1980s, screening mammography became popular, and it's been shown that the mortality of breast cancer has decreased about 40% from 1980 to our current date, to about 2015. The study was done. So a 40% decrease in mortality of a condition is nothing to laugh at. That's very significant. And granted, some of that decrease is believed to be due to better treatment, better surgery, more the more appropriate use of medications and the development of some very new and very powerful treatment options. But a large percent of the decrease was due to the use of screening mammograms. Now, just to break it up, that decrease in mortality is different for different age groups. And certain ages have a very significant decrease, a much greater decrease in mortality, while other age groups, the decrease in mortality is less. So if you break it up into 10-year periods, like age 40 to 50, 50 to 60, the people who are in the earlier group, the 40 to 50 group, their decrease in mortality was only a few percent. It wasn't dramatic. And different studies give different numbers. So there's some question about how much people in their 40s benefit from mammograms. And that's a controversial issue. People in their 50s clearly benefit from mammograms, and the decrease in mortality in that group was about 15%. When you get to your 60s, that's when screening really shines. And the people in their 60s, 60 to 70, had a decrease in mortality of about 35%. And then after that, it kind of slows down a little bit more because the natural course of the disease is much less aggressive in later years. So different age groups have different levels of benefit. Now, people say, people want to know who should have a mammogram. Do I need a mammogram, and how often should I get one? And to answer that question, you have to identify three issues. One is your age, the density of your breasts, and the level of risk. So those are the three things that determine what level of screening, what tests you should have done, how frequently you should have it, and whether there's any other testing that's appropriate after the screening test. So in terms of age, everybody wants to know, what age should I start having the mammogram done? And there's been some different ages that are offered, but I'm going to tell you the current recommendation is if you have average risk, no special issues with your breast cancer risk, you should start having a mammogram yearly at age 40. Okay. If you have a higher level of risk, you might start a little bit earlier. And if you have dense breasts, that also means you should definitely start at age 40. You don't really need to wait, shouldn't necessarily wait to age 50. And in addition, some type of supplemental screen is appropriate. If you have dense breasts, a mammogram by itself is probably not appropriate. You should have other additional testing. Okay. So I'm going to kind of wrap it up. I'm going to kind of summarize what I've told you. I think this is the kind of length of little presentation I think is best, but I'm going to summarize the current recommendations for screening mammograms. And it's very confusing. People really, doctors are confused too. And that's because a number of different national organizations have offered guidelines for screening mammograms. And the guidelines are all slightly different. So depending on what news program you listen to or what newspaper you might have picked up, you might have been advised by some different national organization on what the best screening program is. So what I'm going to tell you is kind of what my colleagues, the radiologists here, and what most doctors in our community are doing. And that's the following. If you have normal risk, that means no special risk factors for breast cancer, yearly mammograms at age 40. And you can continue up until any age. It's really a personal thing. It's covered by your insurance up until you're 99 or 100. However, once you get to your later years, the benefit is less because breast cancer is a slow growing condition. And so the standard thing is that if you have a life expectancy of less than 10 years, probably you should focus on other things like enjoying your grandkids or trip to Bermuda. Screening mammograms are not as critical at that age. The use of sonograms, even though there are no standard recommendations for using sonograms for screening tests, everybody does it. I order it. The doctor next door orders it. The doctor down the street orders it. Everybody orders it. There's nothing really wrong with getting a sonogram every year. and it has some benefits. I personally think that screening sonograms are very important if you have dense breasts, less important if you have lower level of density. And don't just take somebody's word saying, oh, your breasts are dense. And a lot of gynecologists just say, oh, your breasts are dense. You have to look at the mammogram report. That mammogram report will have a level of density on it, A, B, C, or D. If you're in the top groups, the C or D density groups, sonogram every year is a good idea. If you happen to be in a group of people that have very high risk, we're talking about BRCA positive patients, patients with first degree relatives with breast cancer, people with density and first degree relatives, or people who have had a biopsy that showed a premalignant condition, then some type of advanced supplemental high risk screening is appropriate. There it gets a little bit complicated, but suffice it to say, the national recommendations are if you have a very high level of risk, you should be getting supplemental screening with MRIs or some other similar technique. At Mercy, we use the molecular breast imaging, which has certain advantages. So that is the conclusion of what I had prepared to talk about. And now I'm interested in fielding any questions.
Yeah, well, it's so interesting because I had a mammography, I guess. And in the past, I did have the sonogram because I have dense breasts. But this last time she didn't she didn't write up, for one. So I don't know why, does it, the mammography came out all right. I had a physical exam, that was okay. But, I'm older now, so I don't know. Like you said, when you get older, it's, although my friend developed breast cancer at 88, so I don't know, if that's really a criteria. You said age,
Well, for my patients, if they want a mammogram, I'm happy to order it. If they can walk in the door, they're young enough to have a mammogram. I don't really discriminate. Although some doctors do, and the national guidelines do discourage screening mammography in people over 80. That's kind of discouraged. And the reason for that, not because they don't think it's going to help a certain individual, but because when you make national guidelines, you have to take into account the finances of medicine. And if everybody had mammograms every year in every nursing home in the country, that would put a huge burden on the screening program and medical costs. So they discourage that. But if you're 85, you're up and around, and you're interested in breast health, there's no reason why you can't have a mammogram.
But I'm surprised that she didn't ask for the sonogram, because in the past I've had it. The last time she didn't. I don't know.
Did you ask her if you could?
I didn't even really. I didn't. I didn't.
Yeah.
But
well, you're certainly entitled to have a sonogram if you want one. And maybe it's a breast density issue, or maybe she didn't think of it. And I would say if you're interested in doing it, you should just ask her about it.
Well, as I said, I recently had a checkup, and the doctor did examine my breasts, and he didn't find any, anything. So how important is that, a physical exam of the breast?
Well, with these screening tests, we're looking for tumors less than a centimeter in size. And that's not going to, you're not going to be able to feel that in most situations. So the physical exam is important, and the whole doctor-patient interaction is important. So I don't discourage that, but it's well known that for screening, a physical exam is not really adequate, either done by the patient or by the doctor. It's only going to pick up bigger tumors that should have been picked up earlier.
Because many years ago, I did have well, it was benign, but I did have surgery on that. But that was 35, 40 years ago. And since then, I haven't had any problem. So. Yeah.
Well, it's a good idea to be examined once a year. Yeah, I encourage my patients to check themselves every month briefly, not more than that. Don't have to make a fetish out of it. Just once a month is plenty. And then once a year, have a mammogram. And I encourage the sonogram too. And part of it is the patients, it engages the patient. They have a sonogram, they're more involved. They think more screening is being done. It's really, the only harm from screening sonograms is there's a higher level of false positives. In other words,
Ah,
if something shows up in the mammogram, you can kind of tell if it's cancerous or not. With the sonogram, there's a lot of vague things that show up that end up getting biopsied and turn out to be nothing. And although a biopsy is not really that harmful, there's costs involved, lost work, discomfort. And if you add it up on a national scale, all the number of false positives, unnecessary biopsies, if you had made a national guideline for breast screening with sonography, it would add up to a huge amount of money and wasted effort. So that's why it's discouraged.
hmm.
But for any individual, sonogram is up to you, and that's up to the doctor. And we do it. Everybody does it.
I've never had I've never had a sonogram. I've always had a mammogram. I don't have, thank God, I don't have any risk factors, or so they've never asked me to do a sonogram. And I'm in my 60s. I'm my early 60s.
Is it ordered by your gynecologist, or who orders the test?
Yeah, the gynecologist. It's always the same. I've been doing this a long time.
And do you know your breast density?
I'm not particularly dense.
Do you know what it says in your mammogram in terms of the description? There should be a description of your mammogram report of breast density.
You know, I don't think I ever paid that much attention because he didn't pay that much attention, but I probably should. Like, what's the number? That's important for me to look at. Like, what should I be, what number should it be? Or
okay, well, it's actually a letter, A, B, C, or D.
Okay.
And these density reports are mandated by the government. However, it's a contentious issue. And so the radiologists have kind of skirted around it because I'm not really sure exactly why, but some radiologists, they're required to make a statement about the breast density in the mammogram report. And so a lot of them make a generic statement about breast density without really identifying your level of density. That's not right. It should have a phrase on the mammogram report. It has one of 4 different phrases: primarily, predominantly fatty, scattered fibroglandular, heterogeneously dense, or extremely dense. One of those 4 phrases should be on the report. And it's typically under a line titled composition or density or something like that. It should be very obvious. And it's the top 2, the heterogeneously dense and the extremely dense. Those are C and D, BI-RADS C and D. It will say BI-RADS 1, 2, 3. It'll have a BI-RADS number. That's the level of abnormality. The BI-RADS letter is the level of density. And they do not put the letter on the test result, but they will have a phrase with one of those 4 terms.
Okay.
Yeah. And when you see that phrase, you'll know if you're C or D. If you're C or D, you should definitely have a sonogram. And that's on the guidelines too. The guidelines say that.
That's so interesting.
I never, no one ever said a word to me. I have no idea. That's very important. Yeah.
I've always had it except this last time.
So
is there any, the x-ray, the mammography, does that have any particular, x-ray problem? I know that sometimes people don't want to take, too many x-rays because of the radiation.
Yeah. Well, there's radiation involved in mammograms. It is, believed, and there's been 40 years of evidence that the benefit outweighs the risk, but there's some risk of any level of radiation. But you get radiation just walking out on the street. You take an airplane flight, you get your whole body gets radiation from the cosmic rays. And these things are, they're quantifiable. So like, if you have if you fly from here to California on an airplane, that's about the same as a mammogram, dose of a mammogram, the amount of radiation you get. And so I would say unless you're having a mammogram excessively or multiple callbacks, I don't think you need to worry about it.
And the sonogram?
There's no radiation at all. It uses a different physical modalities, sound waves.
Right.
Yeah. I actually have to go I have a case at 10 o'clock, so I have to move along now.
Okay.
But I really appreciate the opportunity to talk to you.
Thank you so much. It was very interesting, and you definitely are a wealth of information. We appreciate it very much.
Thank you.
Okay. Okay. Well, you take care of yourself, and we're glad that you came. Thank you.
Thank you very much.
All right. Take care.